Hope you can get me well. So Addison's disease results from the destruction of the bilateral adrenal cortex, leading to decreased adrenocortical hormones. The adrenocortical hormones include the cortisol hormone, aldosterone hormone, and androgen hormone. So cortisol hormone is a hormone that influences metabolism, immune response, and helps the body respond to stress. Aldosterone hormone regulates sodium and potassium balance, thus controlling blood pressure and fluid balance. Androgens cause sexual development in male and influences muscle mass and libido and a sense of well-being in both male and women. So the primary cause in developed countries is autoimmune adrenalitis, while infections like tuberculosis are common causes globally. This adrenal axis lead to elevated ACTH levels and hyperpigmentation due to melanocyte stimulating cross-section. So the ACTH the elevation in the cells is due to the body's action trying to increase the cortisol levels after the adrenal cortex is distracted. Next slide. The etiology or causes of the Addison's disease include autoimmune adrenalitis. The infectious causes are tuberculosis, HIV, cytomegalovirus, and fungal infections. Infiltrative causes include amyloidosis, hemochromatosis, metastatic cancer. Vascular causes include adrenal hemorrhage, for example, sepsis and anticoagulation. Genetic causes or metabolic causes include the congenital adrenal hyperplasia and adrenoleukodystrophy. Iatrogenic causes include the bilateral adrenalectomy and drugs like ketoconazole. So, the autoimmune adrenalitis can result from the type 1 autoimmune polyglandular syndrome, which is manifested by autoimmune endocrinopathy and candidiasis and ectodermal dysplasia. Next slide. The pathogenesis of the Addison's disease. Pathogenesis, the development and progression of a disease and the clinical signs and symptoms in the individual. The pathogenesis of Addison's is first, the decrease in cortisol, which is the glucocorticoid deficiency. Glucocorticoid deficiency refers to the impaired vascular tone, which is the dysfunction in the ability of blood vessels to constrict or dilate in response to physiological signals. The impaired gluconeogenesis and impaired stress response also leads to Addison's disease and hypotension, which is a sign of Addison's disease. Next slide. So the feedback loop for the glucocorticoid deficiency, which is the deficiency in cortisol, the decrease in cortisol due to Addison's disease is caused by the destruction of the adrenal cortex, stimulates the hypothalamus to release. The hypothalamus detects the low cortisol and responds by increasing the corticotropin releasing hormone production. The corticotropin releasing hormone then stimulates the pituitary gland to produce more ACTH in an attempt to stimulate the adrenal glands to make more cortisol. So the next pathogenesis is the mineralocorticoid deficiency, which is the decrease in aldosterone hormone. The decrease in aldosterone hormones means that the sodium reabsorption in the body is reduced, and also there is increased potassium retention and reduced hydrogen secretion in the blood. The decrease in aldosterone hormone leads to hyponatremia, which is the decrease in sodium level in the blood, hyperkalemia, which is the decrease in potassium level, hyperkalemia, which is the increase in potassium level, metabolic acidosis, that is reduced hydrogen secretion, also hypotension. Hypertension is the low blood pressure. Next, that is androgen deficiency. Androgen deficiency. That enzyme, hormone, a hormone precursor for the synthesis of androgens and estrogens. The hormone affects women by reducing axillary or pubic hair and reducing libido. The clinical cause of the disease. The clinical consequences of the disease can either be chronic or acute. The chronic consequences include muscle weaknesses, decreased appetite, fatigue, weight loss, nausea, salt cravings, the hypotension, hyponatremia, hyperkalemia, and hypoglycemia. I hope you all know the definition of those terms. That is hypotension, low blood pressure, hyponatremia, and low sodium, hyperkalemia, high potassium. Acute clinical consequences include the vascular collapse and coma, hypoglycemia. I'm done.
Thank you. That was quite fast. So just a minute. So pathophysiology of Addison's disease and also the Cushing syndrome. Addison's disease, which is chronic endocrine disorder, where now the adrenal glands are not able to secrete or to produce enough of the cortisol and also the aldosterone. So, of course, the basic pathway of how the normal adrenal function from the hypothalamus releasing the CRH, that's the corticotropin releasing hormone, then the pituitary gland releasing the adenocorticotropic hormone, and then the adrenal cortex going to respond to ACTH by producing the cortisol, which is a stress hormone, and then the aldosterone, which regulates the sodium, potassium, and the water balance. Now, with the Addison's disease, which we also refer to as the primary adrenal insufficiency, the adrenal cortex is damaged, mostly as a result of autoimmune destruction, and such it fails now to produce cortisol and also the aldosterone despite normal or high ACTH levels. So what will now mean there, we'll have the hormone deficiency of cortisol, and that means that now one will have poor stress response, there'll be hypoglycemia, there'll be fatigue, there'll be weight loss, there'll be nausea, there'll be vomiting. For cortisol, for aldosterone, there'll be sodium loss. With sodium loss now, that is hyponatremia, which leads now with hyponatremia, there'll be potassium retention, dehydration, and then hypotension. So then, of course, the diagnostics, that one will look at that, of course, checking out the cortisol levels, the aldosterone levels, electrolytes imbalances. Then for Cushing syndrome, which is now caused by prolonged exposure to high levels of cortisol, that's the hypercortisolism. So either exogenous cause, like long-term use of corticosteroids, which is the most common cause, like the prednisone, endogenous like a pituitary tumor, disease. So with now Cushing's syndrome, excess cortisol could be as a result of presence of a tumor, which increases the ACTH levels, that adrenocorticotropic hormone levels, or the cortisol levels are also increased, and the negative feedback system now is going to fail, and there'll be continued cortisol overproduction, and the effects will be of excess cortisol will be enormous. We'll have like metabolic effects where there'll be hyperglycemia, which will affect, of course, protein breakdown. There'll be muscle wasting. Moon face will present. You'll just check out how moon face looks like. Buffalo hump on the back, and one can present with also central obesity, purple stria, that is stretch marks on the body, slow wound healing, hypertension will also come in, hypokalemia. If there's hypokalemia, then you'll expect that there'll be hypernatremia. There'll be increased risk for infections, menstrual irregularities, decreased lipidol in patients. So to diagnose that, of course, you look at the elevated serum cortisol levels. You should do what we call the dexamethasone suppression test. While one is administered the dexamethasone, the cortisol levels will fail to decrease because they are elevated beyond the normal levels. So any question on that? Addison's disease and Cushing's syndrome? Swali?